Hi guys, good evening. Sorry, I was unable to share the screen. I got it now. It was not coming actually. I think because it did not join from the app. Anyway, so today's topic for discussion is actually a large topic, trauma and burns. So we shall be discussing trauma, burns, and a little bit on drowning. These are the three main topics that comes from these related things. So we shall be doing a long case on trauma, a few short case-based vignettes on trauma, and followed by drowning and bonds. So this is the first vignette. So any one of you can. So I think it will be like the other classes of mine on this platform. So one of you just unmute yourself and answer the questions. I shall be reading through the scenario. Just listen to me. So 42 years old man was brought to the ER in an ambulance with a history of fall from third floor. She was on adipiprazole and last 4 days she seemed to be unwell and not very communicative. On arrival, she had a saturation of 87% and 12 liters NRBM, respiratory rate of 28, heart rate of 114, blood pressure 100 by 50, GCS of E3, V4, M5. She had bleeding from the right leg, pain at the back of the neck, chest, legs. The ER team activated a trauma code, secured two large bore IV access, and started a primary survey. So, because this is a teaching class, so I shall also do something. Yeah. So what we can see here, this is a young, middle-aged man who has been brought following a history of fall from the third floor on aripiprazole, and last 4 days not very communicative. So this line is possibly not that important. Okay, last 4 days she seemed to be unwell, not very communicative. This is just a background to this person with a history of trauma. But still, I think you guys have practiced this. It will be like a blank sheet of paper, right? Suppose this is your blank sheet of paper that you will get in your exam day. So you shall divide it into 4 parts. In the first part, the very basics like the age, the history, any comorbidity, these things you shall write in this part. The second part, the basics, vitals. So whatever written here, you should write here the vitals. The third part, any ECG, chest X-ray, any other investigation that they have done, plus any blood investigations. And the fourth part is possible questions. So the possible questions will be, how will you approach the patient? What are the DDs? What are the primary, primary life-saving things that we'll do for this patient? Things like this, followed by investigations, treatment, these things. And as we know, in trauma patient, we can have different questions like primary survey, adjuncts, Canadian C-spine rule, right? And we shall also have the death triad or the lethal triad, and how to manage that. We shall have the hypotensive resuscitation, the blood volume based resuscitations, why the coagulopathy and the metabolic acidosis is bad and how to manage them. So questions like these, and specific traumas like a traumatic brain injury, an abdominal trauma, a spinal trauma, a chest trauma. So things like this. In a chest trauma, we can have a pneumothorax, we can have a aortic dissection and tamponade, and of course the other things like the hemothorax, things like that, or contusions, then massive blood transfusion protocols. So lots and lots of things you can get from question of trauma. So this fourth part is very important. However, if you get some other case like a sepsis case, so these three will be the same. You shall note down the basics of the case, the vitals of the patient, the investigation provided to you, the blood investigation, chest X-ray, ECG, echo, whatever. What cultures have been sent. This I am talking about a sepsis case, and here you shall note down the what cultures, then the sepsis protocols, what antibiotics will you use, what other investigations will you do. So those are the possible questions. Definition of VAP, or I mean, they will not ask definition of VAP, but they will ask something clinically related. So this part is for you guys. The more a person is practiced, the more better they can guess the questions here, because once the questions start after the 20 minutes, then you will have very little time to think, and then you will have to answer those questions. Okay, so that is why this fourth box is very important. So I think by now everybody has got ample time to read the vignette. And here it's a very basic thing. There's bleeding in the right leg, pain at different parts of the body, including the back of the neck, which is very significant, right? And we have started a primary survey. So now the question is, how will you assess the patient? Just one of you unmute yourself and tell me, and then I shall fill in the gaps. Okay? Just let's do it fast, because otherwise we shall not be able to complete.
Okay.
Yeah.
Can I start?
Please. Doctor, please, you can just start.
Okay. Thank you, sir. For this patient who has just fallen from a height and appeared to be polytraumatized, just like you said, the first approach is to carry out a primary survey, which is designed to quickly search for life-threatening injuries using the A to E approach. A is airway assessment. We're looking for any cause of airway obstruction. Then breathe for breathing. We search for any disease process that may be associated with maybe causing breathing difficulties, like we look for pneumothorax, look for pneumothorax or hemothorax, just specifically search out for that. And then C is circulation, which includes stopping that bleeding that is ongoing in his limbs. And then, of course, assessing the circulation for hypotension. Okay, and D is for disability. In this case, we are specifically looking for signs of serious illness like head injury, where the GCS is quickly assessed. And then E is we try to look out for other occult injuries that may be life-threatening, like maybe bleeding from the scalp or any other place. This would be the primary survey that to be carried out. And while its effect is detected, is treated immediately. That's in terms of resuscitation. If he's seen to have maybe airway obstruction, it is suction is applied to suck out maybe blood clots from the airway, and then ensure that the airway is patent and that he's breathing. If respiration needs to be supported with maybe the ambu bag, it is given. Okay, and if there is any impairment in respiration, say from pneumothorax, that will require immediate decompression, it's undertaken. And then from the solid circulation, we may need to, increase, give some fluids if there is hypotension, at least ab initio, and so on. And bleeding spots will need to be secured immediately, maybe with pressure dressings. So this is how I will approach this patient in the course of the primary survey.
Okay. So basically, whatever you said is absolutely correct, but we have to touch a few more points. So first is the primary survey, as you told. So A, B, C, D, E approach. So we have to be very pinpoint. So here for airway, you shall see whether there is an obstruction from bleeding or any tracheal injury. Then breathing, yeah, you should see the respiratory rate, the respiratory pattern, and you should also do a POCUS, bedside POCUS, to rule out any pneumothorax or any obvious large collections. Then you shall circulation, apart from the pulse, blood pressure, you shall be doing a volume assessment, and in the POCUS you shall check for any cardiac tamponade and the basic ejection fraction. Then finally disability, and you shall of course remove the clothings and everything to check for any fractures, any bleedings, any pelvic, any obvious pelvic any any pelvic injuries. And you shall also be looking at what you should also looking obviously for the GCS, because GCS and the back of the neck for any any pain. As I mentioned here, this pain and the patient has fallen on the third floor. So that part is very important. So this is what you shall be telling in the ABCDE approach. Apart from that, you shall be you shall be arranging for blood products, and the patient is in the ED, right? So you need to tell where you shall shift the patient, or you shall do something in the ED itself or not. You shall have to go for an EFAST, right? Fall from the height. EFAST and a multidisciplinary team, including the the emergency team, then the surgeon and the orthopedician, they need to be consulted. And finally, fifth is, if you feel that the patient, because the patient has got what bleeding from the right leg, so this needs to be assessed. So this needs to be assessed, and there is also pain at the chest and the legs. So the POCUS, the EFAST, then CT scan, all these things are very important. So those the investigations, those you need to mention. So it's not like you have to mention it in this order, but these things you need to mention whenever you get a case of trauma. And yeah, you can, of course, all of these are mostly included in the ABCDE approach, but these specific things, blood products, EFAS, CT scan, multidisciplinary team, and investigations, you also have to tell. Then there is something called a second 10-second rule components. The 10-second rule components, as you can see, I have already written down the answer because this is something which has been asked previously in the exam, and it's something which most of us will not know. It means that the patient needs to ID himself by name and where it happened, what has happened, and can describe it. So these are the three questions for 10-second rule. Can the patient identify himself? Can he tell what has happened, and can he tell what where it has happened, and can he describe what has happened? So the third question is, how will you assess the spine? So somebody unmute yourself and just tell me what you usually do to assess the spine, to assess the cervical spine.
Okay, can I try?
Yeah, please.
Okay. One of the first things to do to assess the spine is to determine the level of consciousness of the patient. If the patient so I will first talk to the person. If he's conscious, then I'll ask him if he's having pain in the neck, as in this case, and otherwise I'll instruct him to move his neck. Now, but if the patient is unconscious, I will automatically assume that there is spine injury, especially with the history given, and I will request for imaging to look out for injuries to the spine. I'll request for plain CT scan of the neck to assess the cervical vertebrae. He may have some fractures. But meanwhile, I would have once he's unconscious, I will apply my neck cervical collar to stabilize it. In fact, that's for an unconscious patient. That's one of the things that will be undertaken as part of the ABC, the A of ABC, spine stabilization.
Okay. So you see, there is something called a Canadian C-spine rule and something called a Nexus rule. You can remember any one of them, obviously. But the Canadian C-spine rule is, it's actually my last slide, yeah. So this is the Canadian C-spine rule. So you see, first you have to know what are the high risk factors: age, dangerous mechanisms, numbness or tingling in the extremities. And obviously, the second thing you need to know is what are the dangerous mechanisms: fall more than 3 feet 5 stairs, axial load to the head, speed more than 100 kilometers per hour, ejection, rollover from vehicles, bicycle collision with objects. Okay, so all these things. So if either one of these is yes, any one, then directly you need to go for a C-spine immobilization. If all of them are no, but low risk factors are present, these are the low risk factors. Or if these are not present, those are also low risk factors. Then you may think that may not need C-spine immobilization. But if either of them are present, then basically patient voluntarily able to actively rotate the neck. Any pain, if pain or unable to, then again immobilization. If no pain, then no immobilization needed. So first is you have to see any high risk factors, any dangerous mechanisms, any low risk factors. If either of them are present, then C-spine immobilization will be needed. If no, then we can think that no C-spine will be needed. So this is how we need to know. And these values are very important. 3 feet 5 stairs, 100 kilometers per hour, these three things. And age more than 65 years. Here already it has told that it is from three stories height. So obviously it's a dangerous mechanism, right? So, and there is also pain in the back of the neck. So immobilization will be needed. I hope you guys understood that how to assess the spine, because this will be asked. If you get a trauma case, this will definitely be asked. Next is approach to the patient after primary survey. So I think one person is telling. If anybody else is interested, then that person can also tell. Otherwise, we shall continue with whoever was giving the answer, the last two answers. I just want everybody to interact. That's why. Otherwise, it's okay. So what do you need to do after the primary survey? And what are the adjuncts to the primary survey?
Let me try. I thought
Yeah,
the
yeah.
adjunct to the primary survey consists of the investigations you had already mentioned, such as point of care ultrasound, including EFAST to assess the presence of the assess abdominal for abdominal trauma or abdominal for hemoperitoneum, and then of course the point of care ultrasound to check for chest trauma, such as look out for tamponade, cardiac tamponade, and hemothorax. Then apart from that,
Okay.
need an urgent chest X-ray, urgent chest X-ray, including pelvic X-ray in this instance, and subsequently, we might, if the patient is a bit stable, can be moved for pan CT to look out for occult.
Yeah, exactly. So, doctor, you obviously have the basic idea, and you are correct also. So, the first thing is we have to keep on looking for the vitals, the serial physical examination. Okay, that is one serial physical examination. The second thing is, arterial blood gases, capnography, respiratory rate, those things. The third thing is uh, chest X-ray, EFAST, FAST, POCUS, DPLs, those things. DPL, FAST, EFAST, these things. Chest X-ray, pelvic examination, pelvic X-rays, those things are also there. The other last thing is the urinary catheter, Foley's, Ryle's tube, okay, and ABG ECG. So if you, I when I used to study, I used to remember it this way. One is physical examination. Second are the ABG ECGs, which you can do at the bedside. Third thing are the scans. Fourth thing are the X-rays. And fifth, the devices you can put in urinary, that is the Foley's catheter and the Ryle's tube. So this is obviously as per the ATLS. Everything in trauma is as per the ATLS, right? Otherwise, we can tell anything which you like, which will probably be correct, but you have to always give the answer as per ATLS guidelines. So these are the adjuncts to primary survey. So next is what's C-spine imaging, how to decide. This we have already discussed, how to decide. This is the Canadian C-spine rule. If you want to do the nexus rule, that is also okay. Any one of them I think is fine. Just remember both the names. But whatever you tell, Canadian C-spine rule, those clauses, the speed, the height, those things are a must. Yeah. So these two questions. What is the role of tranexamic acid in trauma? Can somebody tell me?
Yes, I can say something about it. Yeah.
Yeah, Dr. Hero, please tell.
Yeah. In patients with ongoing bleeding following trauma, it's been shown that tranexamic acid can be very helpful in controlling the hemorrhage, at least within the first 24 hours. So usually when patients have been confirmed to have bleeding, such as hemoperitoneum, they should be given at least 1 gram of tranexamic acid start, followed by maybe 500, 8 hourly for the next 24 hours. So it's been, I think there's a trial that a very popular trial that actually showed that.
What is the name of the trial?
Um, um, I can't remember now. I used to know it.
It's fine. It's
It's
Crash 2.
a crash 2 trial.
Crash trial.
Yeah.
Crash. Okay, there's even Crash 1 to 4 trials for different scenarios. Crash 1 to 4, yeah. That's correct. So it has
So, Doctor, what is the
a
Crash
significant
1
role
trial?
in trauma patients. Yeah. Okay.
What did the Crash 1 trial tell?
Okay, it should be the Crash 2 that you have typed here.
Yeah, the trauma trial is Crash 2 trial. Tranexamic acid in trauma is Crash 2. And it told what you told. It's 1 gram IV tranexamic acid over 10 minutes loading, followed by 1 gram IV every 8 hourly is, it decreases mortality, right? So that is Crash 2. That is okay. I am telling what did Crash 1 tell and what did Crash 3 tell.
I can't remember exactly.
Fine. So Crash 1, yeah. So just let me tell you, all of you, Crash 1 trial is corticosteroid use after head injury. Corticosteroid use in TBI. Okay. So that idea was whether it reduced swelling and all those things. It was found that it actually increased the death rate. It increases the mortality, right?
Yeah.
And it is the reason why steroids are contraindicated in traumatic brain injury patients. That is the finding of the Crash 1 trial. Okay. It's a system changing trial. Yeah, and Crash 3 trial is again tranexamic acid. It showed that in mild to moderate head injuries also it reduced death. So Crash 2 is basically for all trauma patients. Crash 3 is for tranexamic acid in traumatic brain injury patients. Okay.
Yeah.
In generalized trauma patients. Both of them show that there is a reduction in mortality. So Crash 1 is not traumatic, is not Tranexa. It is steroids. Okay. 2 and 3 are Tranexa in different settings. And what were the trials of steroids in C-spine injury?
Yeah, they've been shown to improve, to reduce swelling of the spinal cord in trauma. So they have an important role in patients with.
The trials are these trial names you need to know. Okay, the Naskis trials. Okay, there are again 3 trials: Naskis 1, 2, and 3. The Naskis 1 trial showed that there is no difference in recovery, but there was more infections. Naskis 2 actually showed that there is a better motor function, improved motor function, if the steroids were given within 8 hours of injury. Steroids by 8 hours of injury, right? Better motor function. And this is the result of the trial that we still believe that steroids improve the outcome after injuries, after traumatic brain, C-spine injuries. It is a Naskis 3, which is actually a pretty old trial. It is 1997 trial, which showed that giving steroids for 48 hours was slightly better if treatment was started by 3 to 8 hours. It increased the risk of pneumonia and sepsis, and the overall prognosis after 12 months were the same. Okay. So I don't think you require these details, but the name is definitely important. Naskis 1, 2, 3. It is a Naskis 2 which showed there is a significant improvement in motor functions, and 3 which showed that the motor function improvement did not persist beyond the 12 months. And all three of them showed that there is increased chance of infections, and steroids are only beneficially given within 8 hours of injury. Naskis 3, it showed within 3 to 8 hours of injury given. So early steroids, if you at all want to give. So now we have come to the Vignet 2. We have done an abdominal CT. Patient's ABG has been done, which is more or less fine. There is just mild metabolic acidosis. Some sinus arrhythmia is there. You can see that there is a drop in hemoglobin, and creatinine, those things are okay. Sodium, potassium is okay. Platelet is okay, and sodium is a bit on the lower side, of course. INR is raised 1.6. So we have activated the massive transfusion protocol because there is a fall from third floor. Patient is obviously intubated because of C-spine injury and hemodynamic instability, and is on PCV mode of ventilations. And now we'll have a look at a CT scan of the abdomen. Can somebody tell me what does the CT scan of the abdomen show? Just the 2-3 point that is showing, not the whole thing.
There is an obvious fluid in the abdomen, especially around the kidneys. Around the kidneys, there is fluid there, which in this case we suspect it must be blood, a hemoperitoneum, and that's one thing I can quickly see. And
Okay. So this is of course the liver, and as you can see there is a change in the texture, right? So this is the collection, and in the current scenario, of course, that is blood. So there is a hemoperitoneum is present, right? And what is this? What is this? And what is this? First, tell me what is this?
So the bright part is that not like maybe it's a contrasted scan showing a blush
Which
of
one?
blood, fresh blood. The one
This.
the So you're seeing the kidney that looks like may also be injured, but then what you're seeing in between the liver, I'm presuming it's gonna be the pancreas or something. I have no idea, but there's fresh blood there.
Which one are you telling bleeding? This one?
Yes, the one that you've just squiggled on cross. I'm driving, so if there's a delay, please forgive me. Yes, the one that you've put a squiggle around.
Okay, so doctor, you see, that is basically the stomach, okay? And this patient had undergone a CCT with a oral contrast. So that is basically the contrast in the stomach.
Okay.
Don't worry, don't worry. So that is a common mistake. So that is why I put this cut. So that is the stomach. So you see, these are the structures. First, let me tell you the structures. This is the liver, right?
Yep.
This is the stomach, and this is the spleen here.
Yep.
Okay. So the spleen, if you can see, there is a devascular spleen because the texture is different. Can you see?
Mm-hmm.
Yeah. So this is called the devascular spleen. So this is the surgical emergency. And of course, there is a blood in the around the liver, but the liver as such, there is no gross laceration. So the blood here is because of the injury to the spleen. And this is the stomach with the contrast in it. So that is different thing. So just because, so here you see the blood is collected on the livers, but there is no liver lacerations. The injury is to the spleen. So there is a splenic laceration with a hemoperitoneum. And of course, in a CCT abdomen with a contrast being shown in the stomach. There is no liver laceration. So if you tell liver laceration in the hemoperitoneum, it will be the wrong identification. The liver is more or less okay. It's a spleen which has been grossly devascularized. Fine. So guys, can you just tell me a few severity scoring scores for trauma severity scoring systems? Anybody? So one is the revised trauma score, right? It includes the GCS, systolic blood pressure, and respiratory rate. Extremely practical score used very commonly in the ED. And second one is a shock index. I think we all know the shock index, heart rate by the systolic blood pressure. Value more than 9 often indicates an occult shock. Then we come to the anatomical scores, which is basically the abbreviated injury scale and the injury severity score. Because it takes some time, so they will not ask you to calculate the scores, but the just names are important. But they may ask you to calculate the revised trauma score or the shock index because those are practically used. And the abbreviated injury scale, the injury severity scores, those are excellent scores. The injury severity score is basically the gold standard. So that's what there is. And what about any hemorrhagic scores in trauma? So hemorrhagic scores in trauma was asked to me only. So you can understand how commonly it is asked. To understand the level severity of hemorrhagic shock or bleeding in trauma. So one is the shock index. Second is the ABC, the assessment of blood consumption score, which takes into account penetrating mechanisms or not, systolic blood pressure, heart rate, a positive fast, these things. A score 2 or more indicates a high likelihood of the patient will need a massive blood transfusion. And of course, you have got the ATLS classifications, class 1, 2, 3, 4, based upon blood loss, heart rate, blood pressure, mental status. And we can also have a look at the TASH score, which is a trauma-associated hemorrhage score, which takes into account systolic blood pressure, heart rate, hemoglobin, base excess, and it is a bit more complex. So also into hemoglobin. But this TASH score and the ABC score both can be calculated bedside. So be aware of these scores because you may be asked to calculate the score for your patient. Okay, the TASH and the ABC. The rest I don't think they will ask you to calculate. Keep in mind the shock index and the trauma severity index, the modified severity index score, those sort of things. So can somebody tell me? So this patient already intubated, right? The patient is on PCV. So suppose you have to intubate this patient, what will you do?
Okay, if I have to intubate this particular patient, there are two important considerations. One, this is a trauma case, so he's coming in with full stomach, and it must be considered an intubation. And number two, he has a potential cervical spine injury, and so spine protection must be ensured. So the intubation of this patient will have to follow rapid sequence induction technique, and that means we'll have to intubate him with rapid acting anesthetic agents, with and in this case with the injury, application of cricoid pressure will have to be very cautious. We have to be very cautious with cricoid pressure in this instance, and then
so what precautions will you take? How do you intubate the patient? What is the procedure called?
Okay.
What is the maneuver?
In this case, I will use a manual inline stabilization for him, and that means another colleague will have to be there to stabilize his head and neck together, while and then we'll avoid the head tilt or chin lift, just jaw thrust. Also, during laryngoscopy, and then we may have to preferably use a video laryngoscope with the aid of a bougie, so that
Fine.
to minimize, that's a bougie, to minimize the movement of the neck.
Okay. So there is a name for the maneuver, right? What is it called?
Is it not a manual inline axial stabilization?
Yeah. It's called MILS, manual inline stabilization, the log roll maneuver, right?
Okay.
Yeah. Manual inline stabilization is okay. It's perfect. Manual inline stabilization. Did you tell manual inline stabilization previously? I did not hear it actually. If you are told manual inline stabilization, then it's absolutely okay. So that is how you will intubate the patient, because you see, when you ask this question, to reply very fast. So you tell that I shall follow the manual inline stabilization, I shall do the log roll maneuver, I shall make sure that I have enough helpers with me. I shall divide it into a nursing team and the team who will take care of the airway trolley and the crash cart trolley. I shall make sure that I have got the emergency medications loaded and ready. The medicines which I shall use for sedation and paralysis, those things are ready. I have a working video laryngoscope, bougie as you told. I have got somebody with a front of neck access expertise if possible, and I shall also have adequate help. Yeah, and then you shall tell that how you intubate. They will not allow you to continue, because they are basically trying to see whether you know about the mills, about the log roll, and whether you know that this will be difficult intubation, and so you are calling for help and you are taking adequate precautions before you start the procedure. That's what they're trying to see, rather than the how do the laryngoscope and those sort of things. Okay. So you have come to vignette 3. The patient was planned for extubation on day 4, and now this is a condition. The GCS is E2M4, tachypnea. Saturation is 85% to 60% FiO2. Blood pressure, pulse, as you can see, the patient is basically shock with hypoxic, right? So what will you do for this patient right now?
Well, if I had planned to extubate this patient by day 4 and then suddenly discovered that this patient is hypotensive, the first thing I'll do is to put it on hold, and then reevaluate this patient to determine why he's hypotensive. I will try to find out if he's still heavily sedated. We'll have to, of course, stop the sedation and maybe reassess him generally, check his BP, ensure he's there's adequate circulatory volume. Is check his input output, and to be sure that and
Yeah.
then
So what are
also
the
rule out
possible DDs?
sepsis. Yeah, sir.
So what are the possible DDs in this situation?
Okay. The other possibility is I'll also do neurological assessment, because for a patient with a potential spine injury, he could also be having a spinal shock, and in the presence of a spinal shock, we might not need to start vasopressors for him.
Why do you think this patient has spinal shock?
Well,
After 4 days?
with cervical trauma, with a cervical trauma, there's a possibility that there will be sympathetic
Yeah,
blockade.
that is okay. But why will he develop it after 4 days? You see, in the exam, you have to read everything very carefully. You see, they have told that the patient was planned for extubation on day 4. So, what does it mean? Planned for extubation. So, it means that the patient was doing fine, right? Otherwise, the patient would not have been planned for extubation. So, this is something which has developed suddenly.
That's right.
Right?
Active shock due to pulmonary embolism.
Yeah, it's a pulmonary embolism or a pneumothorax or sudden onset heart failure or AMI, those sort of things, rather than a spinal shock. So that's why I have put this vignette, so that there are, you see, this is the patient in shock. So it can be a hemorrhagic shock, it can be a septic shock, it can be an obstructive shock, it can be a spinal shock, which is basically a distributive shock. So most of the times we can rule out a spinal shock. In the obstructive shock, septic shock, and hemorrhagic shock, we cannot rule out in these patients. We have to see that. So, what investigations we shall do? This is basically a common. Sorry. So
Okay.
this is basically
at least one bedside investigation that we could do, and maybe prior to rule out to rule out a hemorrhagic shock. Okay, I think is assessment of the IVC size, that's IVC ultrasound, and then if his limbs are can be moved, that in relation to his trauma, we could also do a straight leg raising test to check his blood pressure in order
Yeah.
to
So you
assess
see, they
his
have already told
responsiveness.
in the vignette previously that the patient has a injury to the right leg. So in the
Okay.
EDIC part 2, the examination is such that there is nothing called a theoretical point of view. They will give you the scenario, and in that scenario, what you shall do, that you have to tell. So you can't tell in the scenario that the patient does not have an injury in the leg, then I shall do the leg raising test. Here the examiner is waiting
Thank you.
for you to tell the leg raising test so that they do not give you the marks. That is the, in short, that is what is happening. Because you can do every other test that is available other than the leg raising test, passive leg raising test, because that is one of the contraindications, right? You know that very well. And the patient also has got a hemoperitoneum, and possibly the patient underwent a laparotomy also. So that is another contraindication for a passive leg raising test, right?
Yeah.
So you cannot tell the passive leg raising test here. You can tell the
Okay.
IVC, although post laparotomy, how much of an IVC I don't know. So here it is very tricky. Here basically the IVC you cannot see that well for all practical purpose. You cannot do the passive leg raising test, but you can do an echo.
Well, I'll do echo. Yeah.
Yeah,
Echo.
you can do an echo and the POCUS. The POCUS will basically rule out the pneumothorax, the cardiac tamponade. It will give you an evidence of the ejection fraction, and of course the pulmonary embolism, which is also you can see on the echo. And echo, you can see the LVOT, VTI.
Yeah.
Yeah. And if this patient, suppose you have intubated the patient, I mean obviously the patient is not extubated, so you have put the patient back on PCV, sedated, paralyze the patient, then you can again do those things. If there is a CVP and outline, then this pulse pressure variations and those things. But don't do this if the patient is in the PSD mode, because, or if the patient is having arrhythmia, if the patient is on a low tidal volume ventilation, because these are the contraindications where you can't do a PPV. So you see, they will not directly ask you the contraindications. They will give you a scenario where there will be some contraindications, and that you have to find out and you have to decide which test you need to do. That is the basic, fundamental viewpoint of this examination. Okay. So that is what you need to do here. And of course, you need to see whether there is any frank bleeding from somewhere, and USG of the abdomen, any bleeding from the Ryan's tube, from the Foley's, any melena, those sort of things you need to see to rule out the hemorrhagic shock. And if these two are all right, then you can tell that I should also send the blood cultures. And of course, septic shock is a bit unlikely. It is more looks like an hemorrhagic and obstructive shock because of the sudden onset. And you have done the investigations, and somebody told about pulmonary embolism. But I shall recommend, do not tell about pulmonary embolism directly. Tell that these are my DDs, and yeah, I am thinking more in the line of obstructive shock or a hemorrhagic shock, and I shall do these investigations. Because here there is nothing to suggest pulmonary embolism. It can very well be a pneumothorax as well, right? Yeah. So I mean, obviously, I have given away the answer. It's pulmonary embolism. I think it's pretty straightforward. Here
Yeah.
there is a flow. Here there is no flow. There is a complete cutoff. So it's a right-sided massive pulmonary embolism. And so, how will you manage this patient? Tell me that.
Oh, okay. Yeah, because this patient is, at least this has confirmed that there is a pulmonary embolism, and with causing a significant hemodynamic impairment, this patient should be thrombolized immediately. But because he's a trauma patient that has a significant bleeding, I'll maybe prefer this.
So he's a day. So he's on day 4 post
catheter-directed.
laparotomy.
Yeah, this patient is post-laparotomy and has had, so systemic thrombolysis is contraindicated.
Mm-hmm.
And yeah, so I'll go for catheter embolectomy, catheter-directed embolectomy.
Yeah. So here the patient is in shock. So I mean, all of you must be doing it. So first you have to stabilize the patient with some IV fluids, and with the inotropes if needed. And of course you have to go for the definitive therapy, which in this case you can still give heparin infusion can be given even if it is post laparotomy, but of course systemic thrombolysis cannot be done. So yeah, you shall be calling for an interventional cardiologist or interventional radiologist for help, who can do a catheter directed thrombolysis, right? So that will be the full answer. Management we have to discuss already. So now you find out that the patient was not on DVT prophylaxis. Okay. Should this patient have been on DVT prophylaxis previously? Yes, right?
I would say yes. After 24 hours post-trauma or post-surgery, if the patient, there is no sign of active bleeding from anywhere,
Absolutely.
it should be started on DVT prophylaxis, because
So he was not on any
trauma
DVT
and surgery
prophylaxis, neither mechanical nor pharmacological. So now it's it's an European based exam, right? So these sort of things they have to openly address to the relatives also, because their setup is such that they do not hide these things and they tell this to relatives. So now you have been tasked to counsel the relatives regarding this. It's a mistake, right? It's a mistake on the treating team's part. So how do you approach? Communications and ethics is also part of the exam. So how do you approach?
First, I will go and meet them, and I will ask them their names, and I will introduce myself, and I will take them to a setup there, like an office where it is peaceful and silent. And I would like to explain you some difficult news for you. I will tell them, I will ask their permission. Then I will ask them what they know and if they want anyone else also to be present in that room. Then I will address the situation and I will fill the knowledge gaps. Then I will tell them I will apologize them from the team viewpoint, so from the ICU team itself, and then we are taking measures to address these things, and we will raise an appropriate issue in our information portal also, and we'll offer support from our side legally also if anything is required. But this is what happened, and I will make
Yeah.
sure it doesn't
So you are
happen
right
again.
only. Yeah. So you need to meet in the in a private place which is quiet with the member of the family or members of the family who you have been dealing with for this time. Be somebody who has come to the ICU to meet with them, track about the most of the things, which is so that both the parties are at least familiar with each other. And during the meeting you shall be looking eye to eye, you shall be breaking the bad news. There is some protocol, the spikes protocol, which you can go through. It is basically you should be respectful, you should be polite, you should be asking whether how much they know and how much they want to know, and then you shall be giving a brief update of the relative's condition, and then you shall tell that this is the reason that we have come and unfortunately this has happened. And you shall wait, give a pause. So they will wait for some time and then they will either be angry or be sad. So if they're angry, you shall just need to calm them down. You need to let, unfortunately it has happened, but we have taken these things. And then they will be like, we want to raise a complaint. And you shall tell that there is a protocol for that. There is a online on a grievance addressal form which you need to fill up, and there are people who can help you with that. And once you fill, and that part will be thing, and then that part will address accordingly. And even if you don't fill up, and even if you fill up in addition to that, we shall be doing an internal review in our next morbidity mortality meet about why this happened, and so that it doesn't happen in the future. And that's it, because it will be like they will give you hardly 30-40 seconds to address this. So you have to tell as much information as possible, because yeah, so because this is one of the common things, because and this one of the short case or long case you will be given something relevant like this. So you see, after 7 days patient extubated, after 14 hours patient desaturated again. So again, what can be the disease? So you see, whenever they tell you the patient desaturated, then you have to not just confine yourself to this case, but in general, the degrees of desaturation you just think of, right? You need to think about chest, I mean lungs and heart related conditions, and of course the causes of obstructive shock and those things. So you need to address it accordingly. First, you need to look at the vitals, whether stable or not. Then you need to do the POCUS, you do the chest X-ray, ECG, echo, these sort of things. And since it's a trauma patient, so yeah, again, in any bleeding, any the wounds have given up or something like that, in DVT, those kinds of things. So done a chest X-ray and you find out this is the X-ray. Somebody just describe the X-ray for me.
Hi, sir. Hello?
Yeah, please, you can.
Yeah, there is bilateral tracheal consolidation, right upper and middle lobe and lower lobe on the left side. So right middle and upper lobe on the right side and lower middle lobe and left lower lobe.
Yeah. So basically, the patient has developed a new onset hospital acquired pneumonia. And what will be your DDs?
Sorry?
What will be your differentials? The top differentials, maybe one or two top differentials.
So this is possibly gram-negative
No,
rods,
differentials, doctor, not the cause of the pneumonia. If it is like,
differential.
yeah,
So
differential.
so this is hospital-acquired pneumonia, possibly
Okay.
ventilator-associated pneumonia.
Okay, so it means differential heavily fluid overload. Okay.
The differential diagnosis is ARDS in this.
Yeah, differential fluid overload ARDS.
Okay.
Yeah. So this was in very short about trauma because we have burns also. So I did not want to extend the trauma discussion. So this was very briefly about what I wanted to discuss about trauma today. Be very confident about trauma because trauma will be asked in the exam like anything. And trauma, if you read trauma well, you can do the CT scans, the X-rays, and a few ECGs, and a few management of shocks. There's C spines because at least 3-4 questions will be asked on trauma directly and indirectly a few more. So it's a very high yield subject. Okay. So the next part of today is of course burns, and we shall do that. Burns is relatively very straightforward. There are just a few questions which are actually asked on the subject. But yeah, we shall do that. So you are a senior critical care medicine trainee attending a trauma call. You are asked to manage this patient, a 70 years old male patient extracted from a house fire. Neighbors reported hearing an explosion before the fire started. So anybody who has prepared or read through the burns topics immediately knows where this is going, right? There is an explosion, there is a house fire who was extracted. So you know that this is going toward those carbon monoxide poisonings and airway suits, airway trauma, airway burns, and the cyanide poisonings. Those things will be coming, right? Because that is good. If you read this and you think that okay, this is possibly going to that part, then actually you know what is possibly coming, because you have to always be second guessing these things, these common questions. Some uncommon question appears in the exam that is uncommon for everybody. So now the patient has got extensive burn injury involving the face, neck, thorax, right arms. The meals was done as we discussed in the last session, and he has a extreme tachypnea. There is okay, they have already mentioned it. There is soot around the mouth and the nose, and unable to open his eyes due to increasing facial edema. So guys, what is the next step?
The next step is to secure his airways.
Yes, that's what I wanted to hear.
Intubation.
Next step is intubation. So what is the main concern? Give me 3 main concerns of this patient at this point of time. Except the airway, you have already told. Other than that, any 3.
Of course, the next one is fluid management.
Okay. Third, we shall discuss fluid management later. So after that, third.
Okay, and then maybe hypoxemia from carbon monoxide poisoning.
Okay. So basically, because this is also a case of trauma, right? There's an explosion. So one is thing is the fire part. So that part you are dealing with the airway, you are dealing with the fluids, you are dealing with the one even when you secure the airway, there can be spasms and those sort of things. And on top of that, you are maintaining the cervical spine, and the patient has been extracted. So the poisonings, the three poisonings, and there is an explosion. So basically, you are dealing with the trauma patient also. So you can tell that I shall just go through and look for any obvious, injuries, any long bone fractures, any abdominal distensions, and I shall, clinically examine the patient for any of the things we already discussed, basically hemothorax, pneumothorax, any pneumoperitoneums, those sort of things. Okay. So why does this patient have a difficulty airway? Any three reasons.
I think because of the facial burn,
Yeah, one.
and the
Then
patient might have, yeah, and the patient also will have some sort of uh, airway swelling around the, yeah.
okay. So basically, it is because of the airway burns. Firstly, secondly, airway swelling. So airway swelling, so the everything will be narrowed down. Airway burns, you can cause bleeding, and third is those soot and those things will go in, so patient will go into spasm. Okay. So these patients will have a very high tendency to go into hypoxia very fast. That is also there. So assessment of burns, basically you need to read this and then tell me how will you assess the burns and how much fluids will you give to this patient.
So I should assess first the body surface area, which is by rule of 9, and then
Mm-hmm.
the- I should calculate the fluid according to that. So the modified Parkland formula.
It's a
By,
modified Parker, right? So what is the formula?
yes.
And tell me how much fluid is needed here. Suppose he's
So
60 man.
so his weight is
60.
60. So it should be. So you say first the face, which is supposed to be 9, and then anterior chest. I think it's chest and abdomen, or chest only. So the hand,
They actually told that
if
there
the
is a
full,
46. So you don't have to calculate that part, na? They have told there is a 46% of body
okay,
surface.
then
Yeah.
so then 4 by 46, and by the weight.
Yeah, it's
Let
4
me
into
calculate
60.
it.
4 multiplied by 60 multiplied by
By
percentage.
46,
So
yeah.
0.46, right?
It's around
Yeah.
10 to
And
11 liters
then,
it will come, I think, the first
so
half
then
within
one,
the first 8 hours, then
yes,
16
and one
hours
third,
second half.
yeah, one third in the first 8 hours, and the second 2/3 will be over 16 hours. Yes, and it should be crystalloid, ringer lactate possibly.
Okay. So so yeah, so you see, you need to be very fast with these things, okay? Because you need it basically it should be at your tips. Because bonds, they will definitely ask you how much fluids is needed, right? So tell me, what is the role of colloids in the first hours of management of bonds? We all know the role of crystalloids.
Because of the large
So you
percentage
read,
of
but
little
roughly in the
burn.
right place. Okay. Oh, you must. So you go to your preparations and go to your dots, then it will appear. Because
Yeah,
now, according to that, it looks
I
like
think
it is
to
editing
mute
gauge.
yourself, whoever is
And I've
speaking.
just thrown you under the bus because I've
Yeah.
given 10 minutes on care on. But just make a note there that that's not what we did. We didn't give 10 minutes.
Member of the Farz Academy, can you just unmute that person? Yeah. So tell me, what is the role of colloids?
So the role of colloids in order to minimize the use of crystalloids, because
Yeah.
of the extravasation in burn
Yeah.
and high leak.
So any particular formula which uses colloids?
I have no idea.
Okay. Fine. So there are formulas, but yeah, I don't think you need. I mean, there is a modified Brooks formula, Evans formula. Okay, the modified Brooks formula is the one which people still use now. It is basically first you use crystalloids, and once you find out, first 24 hours, and after that you can use colloids for around 30% of the total fluids management. So it's not something which is used, but the role of colloids they can ask you in bonds because everybody uses it practically, and now the modified Brooks formula has also come into the guidelines that once you are done with the modified Parkland for the first 24 hours, you can switch to the modified Brooks. So that's why I've included this question. So it does not come as a surprise in the exam.
Okay.
So concerns, difficulty airway, assessment of burns, calculate amount of fluids. So how do assess the burns? That question not covered. Apart from the percentage of body surface area, is a rule of how to calculate how much percentage is there? Is a rule of 9, right?
Yes.
Yeah.
Well,
And for pediatric, it is 1% of the total body surface area. That is the palm. How many palms are used to cover the total burn area? Right, 1% for each palm. So yeah. So apart from the percentage, what else you need to see?
Then also you need to include the if you're suspecting carbon monoxide poisoning, you need to add
So
extra
first is
percentage.
percentage of burns. Second is
Yes.
the
yeah.
depth of
Second is
burn.
it painful or not? Third is there any
Carbon monoxide.
is the third is there any is there any blisters or not? Fourth is color, whether it's red or white. Fifth is fifth is the depth of the burn. Depth of the burns, how you can calculate whether the epidermis is involved, whether it's the superficial dermis with the epidermis, whether it is epi plus the full of the dermis, that is more than 1/3 or less than 1/3. And then after that, of course, is the muscles, fats, and finally the bones, which is basically the grading of the burn, right? Grade 1, grade 2, grade 3, grade 4 burns, right? And the pain, the more painful it is, the more superficial it is. Blisters, the superficial burns have got more blisters. Color, again, red, warm, everything is with the superficial burns. If somebody is grossly burned, they are almost painless because the nerve fibers are also burned, and that is the kind of very poor prognosis. So that is the very basic understanding that the more red it is, the more swollen it is, the blisters, the more painful it is, and the more wet it is. It is the more superficial burns, the epidermis, the superficial dermis. The more deeper you get, these features are absent. So that is how you assess the burns. Very practical question this, because burns will be a short question, or they will give you an image and tell you to identify the percentage of burns and how to calculate the flow. That will be that. So into very fast, because you will get 30 to 40 seconds maximum to answer that. It will not come with a long case, the burns. So yeah, so as I was telling, so you have done this CT imagings and everything, but there is no gross pathology on CT head. The patient is very much drowsy, right? So you shift to the ICU, and the pH is 7.0. If PO2 is 11.5 kilopascals with 75% FiO2, so patient is grossly hypoxemic. PoCO2 is raised. Lactate is high, carbon monoxide level is 35%. So basically, they're given a diagnosis. But yeah, apart from CO poisoning, what else can it be? In a case of burns, obviously, with a normal CT head.
It can be ARDS as well.
Pardon?
It can be ARDS.
Of course, you can hear the other than that.
And then fluid overload because of the fluid we started with high load of fluid. And then the burn itself can injure the lower airways.
Yeah, so you see, doctor, there can be a lot of variations. ARDS is definitely one of them. You're absolutely right. I won't argue with that. Other than that, they are basically, if you go through a few questions on burns, a few PPTs regarding EDIC2, obviously, you shall get an idea that here they are basically asking about the poisonings, carbon monoxide poisonings, methemoglobinemia, cyanide poisoning, this set of things. Then, of course, you can give an ARDS as a DDs. Okay. We need to practice more and more. The different books are there. If you search on the Google, EDIC 2 related, short answer questions or EDIC 2 related books, you shall get 3-4 books which are freely available over the Telegram and net. And you just need to do those books at least twice. Then you will get an idea how to answer these questions. Because it can be anything, right? It can be pneumothorax also. But in this, a person who has practiced will never tell pneumothorax DD. Here they always tell the ARDS and the poisonings. Okay, because I look, anybody who's giving EDIC 2 is working in critical care and they know most of the answers to the question. Just how you tell the answers to the examiner matters. And yeah, so just practice well, okay, because it's a lot of money. At least it's a lot of money for me. So if you don't do well, then you'll be failing by very few marks, and that will, you'll have to give the answer examination again, a lot of money, be more pressures and everything. So just practice well. So this is basically management of carbon monoxide poisoning. So continue with 100% oxygen. Treat with these agents: hydroxycobalamin, sodium thiosulfate, dicobalt edited. So on day 2, so here at this point you need to make a note that you need to study these poisonings: carbon monoxide poisoning, cyanide poisoning, methylmoglobinemia. It's not possible to cover all the 3 poisonings in burns, in 1 hour of burns and trauma session. So I shall just telling you what to read from this. And then this is another very common question in burns. You find that this is happening. Oxygen requirement is increasing. He is getting worse. Renal function getting bad. Difficult to control his temperature, and in spite of analgesic sedation, and he also appears to be in pain. So what may be going on? What are your DDs?
Worsening of sepsis and rhabdomyolysis.
Excellent. Rhabdomyolysis you need to tell because of the why? Because of the respiratory pressure increasing, renal function deteriorating in a background
Yes.
of burns, and is in pain. So rhabdomyolysis is one of DDs. So what else? Second is sepsis. What else?
You could have fluid overload with abdominal compartment syndrome with a deteriorating renal dysfunction.
Absolutely. That is another excellent DD. After that, doctor, can you just tell me why you thought of abdominal compartment?
Compartment. Because with burns patient, the amount of fluid and crystalloid that we give,
Yeah, that I got. That is okay.
that,
Renal function.
that
What else?
yeah, and the patient also was a blast and a burns, so he could have circumferential burns. That we may
Yeah.
have not have done escharotomies. We probably have this
Yeah.
patient on analgesia who may now have ileus from all of
Now I need
that.
to quiz.
So there may be many reasons, yeah.
Yeah, and any other clue that was there in that question other than what you told? Okay, just check. Yeah, any other clue? You are absolutely correct. Whatever you told, absolutely right. More fluids, eschers, circumferential bond.
Respiratory pressures are increasing.
Yeah, exactly. Exactly, Dr. Menas. Respiratory pressures are increasing. That is another clue to abdominal compartment syndrome. And why is it difficult to control the temperature? What is the DD for that? What is the DD for hypothermia? Apart from sepsis, I mean, apart from sepsis. Okay. So you see, just make a note. These are the things you need to study. Okay. From hypothermia, there can be number 1 is sorry. So apart from sepsis, obviously, number 1 is the neuroleptic malignant syndrome. The second one is the serotonin syndrome. The third one is the sorry. So I mean, these are not DDs here. Okay, I'm just included here because Yeah, because you see, I also, because when I teach it in separately, I always uh, because this is something that you don't see that much, these are hypothermia, but hypothermia questions are asked in the exam. So, the hypothermic syndrome, serotonin syndrome, neuroleptic malignant syndrome, these things, at least be aware of what these are, so that, because in the actual exam, they will give you some clues, like the patient was on any antipsychotics, antidepressants, the patient has got any clonus, the patient has got some seizures, those sort of clues will be given. So, be very careful with those. Here I have just mentioned that, so that when I teach, I just don't forget about to tell about that. It is not mentioned, it is not associated with burns as such. Okay, so here the question is mostly regarding with the abdominal compartment syndrome and rhabdomyolysis. And regarding this hyperthermia, you have to always go to the neuroleptic malignant syndrome, neuroleptic malignant syndrome, and neuroleptic malignant syndrome, serotonin syndrome, and of course if the patient has got any surgery done, etc., and if choline or halothane or any of those vaporizing neuro anesthetics were used, neuromuscular blockers were used, then of course then that can also cause the hypothermia. Yeah, so you see here we know the benefits of bronchoscopy in burns, but what are the risks? Bronchospasms, hemorrhage, atelectasis, infections, raised intracranial pressure. All of these are risks. That is why we usually do not do bronchoscopy unless it's absolutely indicated to clear the airways. So these are the problems. Can just somebody tell me? This is with the second last question. I shall spend 5 to 7 minutes on drowning, and then we shall finish the session. I knew it will be a large session, and of course, I had the technical problem initially. So I shall just go past the 9 p.m. Okay, I should just take 10 minutes more. So, what are the causes of AKI in burns?
One is pre-renal, like
Yeah,
hypovolemia. Is there any
yeah.
vascular injuries or anything
You see,
happened
in the
along with the
exam, the
trauma?
moment you classify the cause of AKI, the examiner is 80% impressed that this person is prepared for the exam. So I know that you have prepared well for the exam immediately. Yeah. Now you tell me what are the causes of pre-renal causes of AKI in burns.
One is hypoperfusion. We need to think of cardiac output. Fluid optimization might be not done correctly. That's why he's having AKA. And we can send urine, and fractional excision of sodium and all we need to think of. And
No.
then,
So you told cardiac output, you told IV fluids, you did not tell hypoxemia. So that is the third. So these three should be the first three of pre-renal. In ICU, these are almost always one of these three which is causing the AKI, right? Then we come to the REN. There can be other things also, of course. The drugs can also cause those things. Those we shall not discuss here because that is unlikely to be causing AKI in burns. Then renal. What are the causes of renal cause of AKI in burns?
renal causes, acute tubular obstruction might be a cause.
Yes. Acute tubular
Yeah.
necrosis.
Yeah.
Yeah. What else?
In rhabdo, tubular
Yes,
obstruction can
exactly,
also.
exactly.
Yeah.
It can be rhabdo. Never forget rhabdo. Whenever they are discussing burns, anything you don't know the answer to, just tell rhabdo. It will probably be right, especially if dealing with AKI. And of course, this rhabdo and rhabdo can be, and the hemoglobin breakdown is also there, so that can also cause an obstruction. And postrenal is of course obstruction by whatever cause, any injury or something like that. That is unlikely. This is the least common cause of AKI in burns. These are the chief causes of AKI in burns. Guys, I hope those of you who are not participating actively, they are also enjoying the sessions, right? Because this is the most interactive session, the trauma AKI burns that I teach. So I hope you guys are enjoying and learning something from the class, because this class uh, once you give the, don't know whether you guys are given the exam previously or not. If somebody is there who is again giving the exam, then they will know that how many questions will actually come in EDIC2 from whatever I'm covering today. Anyway, so having done that, we shall go into drowning. Okay, just the 3 questions that are asked in drowning, nothing extra. So what are the problems of CPR in drowning? So suppose there is a drowned patient, you have rescued the patient and you're giving CPR. So what are the issues? What are the changes you make to the SCRS protocol?
Okay, I was trying to say that one of the most important problem with drowning with respect to CPR is the fact that this patient is likely to be hypothermic, and hypothermia will impair the outcome of CPR. And so warming this patient during the process is critical to achieving ROSC.
Okay. So what do you change? What do you need to do?
Is to warm the patient, at least control the environment, and then ensure the patient is covered up, if it's possible, while the CPR is going on, to have a warmer around. And as soon as the IV line is secured, endovascular warming with warm IV fluids can also be administered, and then temperature monitored while CPR is ongoing.
I think clear the airway first before you start CPR.
Okay. So I should just give them. So first is do not start CPR while still in water. Second is CPR should not be of the compression only variety. You need to give some, bag mask or, whatever, face to mouth, something like that. Third is immediate intubation should be done, obviously. Fourth is avoid all, this is the most important one. Avoid all active attempts to force the water out by placing the person face down or those sort of things that you see in the movies and those things. Okay, that because that will cause aspiration. And do not stop the resuscitation hypothermic drowning victim. Has anybody seen a hypothermic drowning victim being given a CPR? Okay, I don't think anybody has. Even I have seen only one. So that person got revived after 2.5 hours of CPR. Okay, 2.5 hours. This is not related to EDIC2. This is just for practical purpose. The patient had an ROSC. And that patient survived actually with some neurologic problems, but it's nothing severe. The patient was able to walk and everything. Anyway, that's a different thing. But these are the things that are special in case of a hypothermic drowning victim. Second is special considerations for CPR in hypothermia, which actually asked. So there, defibrillation is unlikely below 28. So if core temperature less than 30, defibrillation may be ineffective. So below 28, just do not defibrillate. Below 30, you can attempt once and then repeat after deworming. No resuscitation drugs until the temperature at least 30. Between 30 to 35, adrenaline given at half the usual rate. Deworming is obviously the key. You can use ECMO for deworming also. CPR duration, prolonged resuscitation, and after drop risk, avoid rough handling may trigger arrhythmias. So I hope you guys, this is very commonly found on the internet, so you can just type and find it out. So do not defibrillate till the temperature is okay. Do not give the drugs till temperature is okay. So the rewarming is the key, and CPR duration is prolonged, and arrhythmias are common. So don't change the position of the patient or don't lift hand or leg of the patient in haste. This is another common question. There is no difference. Okay, so there is absolutely no difference. Any other things you find on the internet, that is old information. Yeah. So what are the cardiac issues? The main cardiac issues are these: Brady, Osborne, QT, shivering, VTVF, cardiac arrest. Among them, Osborne and QT prolongation are asked in ECGs of in EDIC2 in a post-drowning patient, hypothermic patient. So be very careful. So yeah, so I got a bit over time, but I think I covered whatever I wanted to cover today.
Can I ask?
Yeah, please ask me a question or something.
So I don't have many books about the EDIC or OSCE-directed exams in intensive care. Is there any way that you would be able to share any references or books, even if PDFs, with us to
So
study?
this is my phone number I have selected. So that is also a Telegram number. Just send me a hi there and just mention that you are preparing for EDIC Part 2 from Farz Academy, and I shall send you the book. Okay.
Brilliant. Yeah. What's the country number? I'm sorry.
Okay.
Like the
You guys are
country code.
international students. Sorry.
Yeah.
Just a minute. Yeah, it's India. Okay. +91.
Thank you very much. Thank you.
You're welcome, doctor. So, guys, I think that's the end of the class. Yeah, I think many of them guys actually responded here. I was not able to see. Yeah, really nice.
Can I ask one question?
Yeah, of course.
I think it will be helpful for others. I don't know, but I'm practicing regularly, so it will be very hectic, like as you know, like everyone. So the thing is, there are a lot of videos in Farz, and there are a lot of books available online also. I don't understand. I'm overloaded. I feel what to complete first so that I can feel confident enough. So that's what I want to ask.
So I don't know what books you are seeing on the internet, but there are hardly
Okay.
3 to 4 books that you need to prepare. I
Okay.
shall just tell you the names also. So I have already given you my contact on Telegram, so you can do that also. And I shall also tell you the
Okay.
names so that it gets easier for you guys. So there is something called data interpretation in critical care medicine
Okay, sir.
by B. Venkatesh and T.J. Morgan. There is
Yes.
something called OSCEs for intensive care medicine, which is a green colored book with a blue line. And there is another book called OSCEs Internal Medicine, Intensive Care Medicine, which you can also do. Okay. So these are the
Okay.
3 books that is very important. The data interpretation book is an Australian book. It is excellent for EDIC Part 2. The questions are a bit difficult, but EDIC 2 is a bit difficult exam. It's not a run of the mill exam. So yeah, you have to be well prepared for that. And guys, I think somebody messaged me on WhatsApp. Do you have Telegram? If you have Telegram, it will be beneficial if you message me there because the books are there. You guys use the Telegram app, right, in your country?
Yeah. I'll text you on Telegram. Okay.
Yeah. Just say Telegram because the books are there.
Brilliant.
Okay.
Thank you.
If nobody has any more, if you have any more questions, you can just text me on this number. Actually, more than happy to help. And others can just message or mail Farz Academy. I shall get back to you guys. See you in the next class whenever it is planned. And thank you.